Hi, this is Brian Kim. I'm going to share with you episode 184 in the Best Way to Do Cataract Surgery series. This is a patient with a very dense hypermature cataract, which we call a Catarock. And you're going to see terminal chop, which I'm able to fracture the lens from the equatorial side, which helps bypass the posterior plate phenomenon. You're also going to see cross chop as well as scissoring chop when there are some posterior adhesions. I'm able to safely amputate those posterior adhesions. You're going to see slow and methodical lens disassembly leveraging mechanical fracturing techniques. So I use a cotton tip to steady the eye, and this is a corneal marker which will help me to center and size the rexus. I'm going to turn the eye all the way to the left side of the screen, and then I'm making my paracentesis incision, making sure I'm flat to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. First on the right side, and then the left side. And with these metal blades, you can see they're triangular in shape, and so remember the external width of the incision is going to be larger than the internal width. This is intracameral lidocaine, and then some intracameral epinephrine, and then some dispersive viscoelastic to coat the corneal endothelium and flatten the anterior capsule. And this is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and then when I'm ready, I turn the cannular towards me and then I enter. This is the sharp tip Haldi Percard forceps. I go in sideways, puncture the center, pull down towards me, grabbing the right side of the tear, making sure the radius is appropriate to what I want. So it helps to set the diameter of the rexus. I go around circumferentially, trying to match the rexus to the corneal mark that I made previously. Again, this low profile rexus forceps is really a wonderful addition to my technique. Burp some viscoelastic out, and this is the capsule fornix hydrodissection technique. I place the cannula under the rexus edge contra-incisionally, point the tip down. I'm able to get a nice wave, a couple of waves there. Decompress the lens on the left side, sweeping and pushing BSS to separate the anterior capsule from the lens. Doing the same thing on the right side as well, and then the lens begins to spin. Again, you can appreciate the density of the lens throughout the maneuvers here, and then of course I was patient at the slit lamp, and I knew this was going to be a dense lens. Adjusting the sleeve, irrigating the surface of the eye. Placing the chopper in now, removing the surface epinuclear material, and then I'm going to turn a bevel up, and we're going to go ahead and sculpt for the terminal chop. So as I'm sculpting, you can see I'm not really going pedal to the metal. I'm pushing little by little, and I'm going pedal down when I'm on the forward stroke. And I'm just being very ginger. I'm going to try to debulk that center. That's really the main part for me. I don't really care about the periphery because I know I can fracture that very easily. It's going after that central core. That central core is so dense, and if I don't debulk it, I will encounter that posterior plate. So I turn bevel down, switch to quadrant removal mode, placing the chopper under the rexus edge contra-incisionally at the level of the equator, fracturing from the terminal side, and that terminal fracture point is propagating all the way through and through. You can see it's not quite all the way through, and rather than stressing the bag anymore, I'm just going to rotate the lens 180 degrees. Of course, the lens is nice and loose, so I feel good about that. Again, placing the chopper under the rexus edge at the level of the equator, fracturing from the terminal side, and now you can see there's complete separation. And so that is the terminal chop technique. Placing the chopper around the right heminucleus, hooking the peripheral lens at the level of the equator, fracturing that right heminucleus in half. That is cross chop. Making sure the lens pieces are separated, I'm placing the chopper around that first quadrant, hooking the peripheral lens, pulling it centrally toward the phaco tip, crushing the lens against the phaco tip as if it is a chopping block. Lifting that first quadrant up with some vacuum, crushing the lens piece, lifting that second piece up, crushing the lens between the instruments, and then emulsifying the lens pieces. You can see how dense the lens is. Even with these small pieces, I'm really taking my time and trying to crush the lens into smaller pieces before I emulsify it. You can see the CDE is already at 6.7, purely from the sculpting during the terminal chop. Placing the chopper around that second quadrant, hooking the peripheral lens, pulling it centered toward the fake tip, fracturing the lens completely in half. Placing the chopper around that fragment, hooking the peripheral lens once again, crushing the lens against the fake tip, and then performing a scissoring chop maneuver if sometimes the posterior aspects of the fracturing doesn't go all the way through, and then you can use the scissoring chop to amputate those posterior adhesions. So you can see, I'm very slow and methodical, especially when the lenses get this thick and dense. I don't really tend to go faster, I go slower. I don't want to use so much energy. I'm very intentional and methodical when I'm crushing the lens between the instruments, trying to make sure my maneuvers are away from the cornea, and just crushing the lens as much as possible with mechanical forces, and then pulsing with the ultrasonic energy. By doing it this way, I have found that the patients come in postoperatively with much clearer corneas when I have this very intentional fracturing technique, when I'm using the instruments to crush the lens into smaller and smaller pieces. So here the lens is a little stubborn, and I turn the chopper sideways again, and I'm just crushing the lens. You can see by holding it sideways, it doesn't go towards the posterior capsule, and I'm able to just get around the lens and then crush it with the instruments. All right, so that first heminucleus gone. I'm turning the second heminucleus in front of me. And in this case, just wanting to coat the cornea a little bit more. So I'm putting more dispersive viscoelastic to coat the corneal endothelium. And remember, because of this technique, I've always learned, you don't want to go really heavy ultrasonic energy after viscoelastic goes in. But I don't really even worry about that because I don't ever do that. And so I hook the peripheral lens, pulling it centered toward the phaco tip, fracturing the lens in half, doing the same thing around that third quadrant, and then use some vacuum to lift that piece up. Amputating the posterior adhesion here with the scissoring chop maneuver, and then using some vacuum to hold the pieces, and then crushing the lens piece between the instruments, and then emulsifying the lens piece. So again, because this technique doesn't rely on heavy-handed amounts of ultrasonic energy, the risk for wound burn is lower. And even though I feel the eye was more viscoelastic, I don't have to worry because I'm not going to go really heavy with the ultrasonic energy. Why? Because I'm using mechanical forces to disassemble the lens rather than just going pedal to metal and eating the pieces. Remember, a lot of people will have just a big quadrant and they'll just go pedal to metal and try to eat that quadrant with phaco. Well, then you're inviting yourself to a wound burn, especially with a dense lens like this. And then you have yourself in a mess because now you're trying to close this wound and it won't because the corneal wound has now shrunk like a cooked piece of bacon. It's just shriveled up and it won't close. And so if you use mechanical forces like I do on every single case, even with these super dense lenses, you're just not going to tend to have wound burn because you're so judicious and sparing with the ultrasonic energy, and you're crushing the lens piece almost painstakingly. I'm crushing the lens into smaller and smaller pieces. So I will not really, again, I will never say never, but the chances of that happening, a wound burn with this technique, is extremely low, especially in comparison with standard traditional ultrasonic energy disassembly lens techniques. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. There's a rock piece there, and I mashed it with the cannula on the INA tip. I always start subincisionally trying to remove the cortical material. I'm getting some conj chemosis because my incision is pretty close to the limbus, and you're going to see some ballooning of the conj because of my fluid. And so the easy fix is to take the eye hand piece out and then just do a little bit of a conj snip with some Westcott scissors. And once you make that little snip, the water can go out and it won't dissect underneath the conj and balloon the conj up. The next day, this is pretty much healed. You'll see very little evidence of the incision there, actually. The conj is going to be well opposed and very low risk for complication at all. Better to have good visibility than struggle with the ballooning and not being able to see. So just snip just a little bit so you can allow that fluid to come out and not dissect underneath the conjunctiva. So you can see a pretty easy removal of the cortex and using polish mode to polish the posterior capsule, especially in the subincisional area. I'm going to pulse the BSS into subincisional capsule fornix. And you can see it's rather clean. I'm going to fill the bag with cohesive viscoelastic. Turn the water off. Fill the bag, and then this is the sweep. Sweeping and polishing the lens epithelial cells off the anterior capsule rhexis edge. Sweeping on the left side and then the right side. And with these super dense lenses, I always prefer a 3-piece lens. I believe this provides more equatorial zonular capsular bag support. And so in these dense lenses, I tend to feel they have more zonulopathy. And so I prefer a 3-piece lens in this context. You can see the injector went in, but as I squeezed it in, some viscoelastic came out. I pushed some more cohesive viscoelastic to fill the capsular bag. Making sure the leading haptic goes into the bag, and as the optic comes out, I rotate my wrist counterclockwise to make sure the optic comes out flat. The trailing haptic is delivered outside of the eye and use a Maltzman to dial the trailing haptic into the bag. So I go in with irrigation off, activate irrigation, make sure I go underneath the lens while the eye is inflated, removing all the viscoelastic from within the bag. Polishing underneath the rhexis edge, removing the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this patient had a Catarock, and I performed terminal chop, which again debulks the central core. If you try to crack from the surface, all you're going to get is a Pac-Man effect, where the hinge and the posterior aspect is not released. It absolutely makes no sense to try to crack from the surface when the adhesion is in the back. So that's why terminal chop makes so much sense. You're fracturing from the posterior side, fracturing from the equatorial side, which is much more easy to access because that's where the chopper can go. And then you can propagate that fracture all the way along. In this case, I rotated 180 degrees and fractured it from the other side as well. But again, I did not encounter a posterior plate by doing it this way. But even when you have a nice separation on these dense lenses, when you're trying to remove the quadrants and the fragments, sometimes you can still have posterior adhesions. That's why the scissoring chop technique is so nice. I'm able to amputate the posterior adhesions, turning the chopper sideways so it's not pointed towards the posterior capsule. When you do it sideways, it's very safe. You can see it. You can amputate those posterior adhesions very clearly without any fear. And you can see utilizing and leveraging mechanical fracturing forces and crushing the lens into smaller and smaller pieces. Very safe. You get clearer corneas postoperatively. Your risk for wound burn is dramatically reduced. And this is why I think this is the best way to do cataract surgery. Don't be that person who goes pedal to the metal and then you just cook that wound like you're cooking a strip of bacon. It shrivels up, and then now you have this gaping hole and you can't close the eye. To me, it makes no sense. And every time I see a wound burn, it just makes me cringe. If you perform these techniques, the chances of wound burn in the hypermature lens is dramatically reduced. And this is why I think this is the best way to do cataract surgery. So I hope this was helpful to you, and I thank you for your attention.